Hey everyone, welcome to House Healthcare on Tuesday, I almost said Thursday, Tuesday, January 30th. We are going to be taking up both 721 and 766 this afternoon. We have Sandy Hoffman with us from DIVA, and I'm going to take a moment just as a sponsor of this bill to put forward my intent of Section 7 before we hear Sandy's testimony. So one of the things that we talk a lot about in this committee, and that we hear a lot from constituents and other legislators, is that Medicaid doesn't cover acupuncture, Medicaid doesn't cover something, And we often have bills on the wall. And it's an interesting process to understand why we do or don't cover something. And I know that DIVA goes through a process outside of us sitting in this room that they determine what they should cover or not cover. So as drafting this bill, my intent was, this section of the bill, my intent was to make that a little bit more transparent and create a process where we could say, look, we have all these bills on the wall, right? Like, instead of picking one off at a time, is there a way we could say, let's look at these and see? Because obviously, if we're asking insurance companies to cover something, it means a cost. So in that conversation with Legislative Counsel, we talked about the CURB board. And so that's where the language came from. Any questions for me as the sponsor on that before we let Sandy do her testimony? Okay, great. Sandy, it's all you.
Muted.
You're muted.
How's that?
Perfect.
Okay. Hi, my name is Sandy Hoffman, for the record, and I am the Deputy Commissioner for the Department of Vermont Health Access. Thanks for having me here today. I think hearing what your intent was, I have written testimony that I'll give you, and then I want to talk about another process that we've implemented at the department that might get at what the intent was too.
Great.
Okay, so basically we're not averse to the suggested changes, but we do have some concerns we wanted to share. The Clinical Utilization Review Board, or the CURB, is a board of 10 clinicians that are scheduled to meet every other month for 90 to 120 minutes. Currently, there are 3 vacancies on the board. In the last 2 months, 2 board members have retired. We were excited that we were up to 9. It has been very difficult to fill those positions. There was a significant effort over the last 2 years to improve the board experience and the recruitment process. The DIVA Clinical Operations team developed a CURB recruitment letter that is reviewed and refined twice a year. That letter is sent to a master list of professional associations to enhance recruitment. And I have a list of groups that received the letter. They include the Vermont Nurse Practitioners Association, Bi-State Primary Care Association, Vermont Association of Hospitals and Health Systems, Vermont Medical Society, Vermont Chapter of American Physical Therapy Association, Vermont Chapter of American Nurse Association, Physical Assistant Academy of Vermont, Vermont Occupational Therapy Association, and Vermont Speech Language Hearing Association. Additionally, the CURB and DERB internal teams work together to communicate about open board positions. Recently, the internal CURB and DERB teams met with the DIVA Communications Director and discussed new approaches such as advertising, engaging current board members to nominate potential new CURB or DERB members, especially when their respective term is ending or they're retiring from the board. This is to show that there has been a commitment to recruitment. It is very challenging. We would welcome recommendations from the legislature and would pursue every qualified referral. The way it has worked since I became involved with the CURB is someone is recommended or contacts the department with interest in participating on the board or submits an application on the governor's website for consideration. Our chief medical officer and nursing operations director review the submitted application and may speak with the potential candidate in an effort to establish the requirement of diverse medical experience. We are also focusing on diversity in general and rurality. We don't want all board members living in Chittenden County, for example. If the candidate meets the requirements, the referral is made to the DIVA commissioner, who then makes the recommendation to the governor. So in short, we are not opposed to these recommendations, but we are concerned for any potential administrative burden or impediment to recruitment this may create. The rest of the proposals outline what is already happening. The CURB and the DERB consult with each other. Our CMO attends and contributes to both. The CURB submits an annual report to the House Committee on Healthcare and Senate Committee on Health and Welfare by January 15th every year. That report summarizes all of the work accomplished by the CURB to include topics reviewed and recommendations. We also post all of the board minutes within 5 days of the meeting. We maintain close contact with our legislative liaison and frequently bring topics to the CURB. A review of the minutes and the annual report would demonstrate that we already do what is being proposed. We're a little concerned with the 30-day prescribed timeline. Generally, I think we meet it. We would expedite if necessary, and we are very thoughtful about how we bring things to the CURB. Whenever possible, we like to research and present data to support the CURB in its review of whatever topic is being brought to them. Finally, the CURB has a work plan that is solidified in January and has flexibility for modification when necessary. We could incorporate legislative asks into the plan easily, again, without legislation. To conclude, we hope that this testimony has demonstrated that the department is already doing much of what this section is seeking to codify without the need for legislative intervention. But I also want to talk about the multidisciplinary team that we put together. It started with the beginning of COVID, and that team is members from many of the units across DVA, and Gainwell, our fiscal agent, also participates. And whenever there is something that comes up, like you mentioned, acupuncture or some treatment that needs exploration, it starts there, and we assign a team to look into it. So there are coders there to determine whether or not coding allows for it. Everything before budget is considered. So everyone talks about whether it makes sense, if there's data that would support the change, and then it goes to the CURB. So we're already looking at it and then bringing it to the CURB. And conversely, if the CURB comes up with something and they say, we really think you should look at this, then we bring it back to the MDT. And the MDT would look at it and assign a clinical staff person to review and report out. So we have processes that we've built in that I don't think this legislation would get what you need, but it may. And if you have folks that you want to recommend, we have openings, and we will figure it out. If you really want to do it the way that it's outlined in there, we can figure it out, but I don't think it's necessary.
Thanks, Sandy. And I will say I don't want to do something that isn't necessary. I just want to do something that's going to get to the intent. So I appreciate that candidness. I have a question. You said there's a work plan that's looked at every year. So can you explain a little bit more about that? Who has input into that? How that's developed?
Well, it started 2 years ago. We start building it in November. We look at the minutes over the past year and see whatever came up during the year that we decided that meaning the CURB, decided that they wanted to look at more. And it could come from someone who joins the CURB. It's a public comment and they're asking for us to look into something. So we would incorporate that into the next year's work plan. We build it in November, and that would be the nursing operations director, the CMO, and we build out based on what we know. And then there are certain things that the CURB must do, like their utilization trends that they have to look at. We have, I think, like 8 categories that we bring to them to review. When we remove PA, I think I mentioned when I was here last week that the CURB looks at the utilization trends to ensure that there's nothing that we should be doing a deeper dive into. Then we build it and bring it to them in January. And in January, we send it to them before the meeting. And
I'm sorry, who's them? The CURB? Okay, thank you.
And then at the CURB meeting in January, we review everything. And this year there were a lot of changes that we made that the CURB suggested. So we moved a lot out and filled things in March, and weight loss drugs was one that they wanted a deeper dive for March. And then I can't think of what the other did. Oh, primary care. Yeah, so those were added to, I think, the March agenda. So they give input on what should be included, and then we, like I said, it goes from 90 minutes to 2 hours. So often we have 20 minutes of wiggle room. So when something comes up, even this legislation I brought to the curb in January and asked for input.
Yeah, and I will say, I read both the report that we got and the minutes from the last couple meetings, and the minutes are really interesting actually to read. So I didn't realize they were out on the website. It was very enlightening. Art, you have a question?
No, I just want to, are we on a certain part?
Sorry, yes, we're in section 7, which is on page 14. So I'm just going to keep asking questions until someone else raises their hand. Go ahead, Leslie.
I just wanted to know how you found those minutes. Is that easy to
They
do?
were sent to me, but yes, I can show you where they are.
That'd be great.
Yes,
Yeah.
yes. The Diva has a section on the website for a curb.
That would be helpful. Thanks.
Melanie?
And maybe I missed it and I apologize if I did. It sounds like Curb is doing a lot of good work and part of the new section 7 is working with the Department of Drug Utilization. Was wondering if you could speak, Sandy, to what you're doing now with that kind of work in Curb.
So the pharmacy unit and the clinical service is part of the clinical services team. So any of the planning that goes on for each of those meetings happens in unison. The CMO, our chief medical officer, attends both and participates in both. And we bring the DERB folks to the curb to provide information to them. And then the chief medical officer brings stuff back to the DERB.
So let's say, and I can't see that far away, but we have a couple bills on the wall about Medicaid. I know doula is one, I think breast milk is one. So I think my thought process in this was, well, we could sit here and pull each one off the wall, right? And do each one and have you come in and testify on each one. But is there a better way to look at what isn't covered by Medicaid that could be covered by Medicaid without having Diva look at everyone on a one-off? And so what I'm hearing is that you do look at items through this multidisciplinary team and Curb, but how, and you might have said this, I apologize, how are the items coming to you? So part of this bill says that the legislature could provide you a list. Are you saying we could do that anyway now?
Yes. Yes,
And
you could do
then-
that now. We also get it from providers. We get it from members. They just say, can you cover this? And then we look to see whether there's a demand, if there's utilization, if correct coding allows it, what the fiscal impact would be, what are the benefits.
And so I think maybe that piece there is maybe we're having the disconnect, because, and even when I read the report, it didn't seem like that information was provided to us. So these are all the things we've looked at through this work plan, and this is all the decisions we made and why. Now, that could be an extensive report, so I don't necessarily want to put that on you, but I think that's part of the disconnect. So, have you already looked at acupuncture? We don't know. So any suggestions there on how we can make that process more transparent?
Well, yes. So, can I think about it a little? I think
Absolutely.
the multidisciplinary team is where I think we need to lean into that. And we need to produce, we do have minutes for that team, and those minutes would reflect what it was that we looked at. Now, I don't think it would be very difficult for us to pull together all of the information at the end of the year and produce a report for you of what we looked at and the decisions that we made. that kind of overlaps a little bit with the PA work group and the curve. So all of those teams doing this work, it turns into this, I think, beautiful process of where
Yeah.
we're really looking at expanding when we can and making really good decisions that also have the operational piece being considered right up in front and the evaluative components. So I think we have a really good system, and I think we can come up with a way to report it out to you.
Okay, I think that would be helpful. And then, an understanding of the best. And maybe you'll come back and say, yeah, just take all the bills off the wall and do one at a time. And that's how we work. Try and change it. We've done for years. But if there's also a way, to say at the end of, if we haven't gotten to something, in July or May when we leave, like, these are things that we would like you to look at while we're gone and come back to. I'm just throwing
That
that
would be
idea.
great. That
Okay.
would be great. We would love that.
Okay, Mari and then Topper.
I would be interested in information from you about whether you have discussed coverage of donor breast milk and doula services specifically.
Ashley's going to be in shortly, right?
Yes. Well, that's her.
Can someone ask it for me? I have
Yes.
a meeting at 2.
Yes.
Thank you.
She knows a lot about that, much more than I do.
If, when all of this information is being gathered, how do you gather, or do you gather information from people that are impacted by the decision? For instance, acupuncture. If people are helped by that, how do you get that information?
Are you aware of the chronic pain initiative that Diva's involved in?
No, I think that would be good for you to talk about if it helps answer the question. Yes.
I would like to send you what that program's about, but that is a program, an initiative that has us partnering with UVM to engage in those, I'll say, what are commonly referred to as alternative approaches to addressing pain. But that might be helpful for you. As far as getting back to people, so if someone asks for an exception to, like, if something isn't covered and they ask for an exception and it's denied, they would get a denial letter. They wouldn't necessarily know all of the background of what happened, why it was denied.
I'd like to give you an example, and then if you could tell me what the process would be to either approve or disapprove. Let's say you have cancer, and part of the resources that you have available as a cancer patient is acupuncture, Reiki, things like that. And let's say I was the cancer patient and I was taking part in those services was really helpful to me. How would a decision be made whether to compensate that person that did it or not? How would you, if you don't do it now, how would you change it? By this clinical group that you're talking about?
Yeah.
Or would you talk to people that actually experience
The benefits
this? Yeah.
of it, we
Sure.
wouldn't have that level of expertise. There wouldn't be just a group of people in the room that said, oh no, this doesn't work. We would reach out and learn about what the practice is. Like we did that with chiropractic care. So
Yeah.
there are differing opinions on whether there's value to chiropractic care. So we had a subject matter expert from the community come and talk to the panel about how chiropractic care benefits people.
And
So,
and would that, go ahead, I'm sorry, go ahead.
so it wasn't just this internal group of Diva clinicians who may or may not have had experience. For the purpose of what you're saying, let's pretend like they don't believe in acupuncture, which is just not accurate. We do, but if they didn't, we didn't just have that group. We would bring in others who might have differing opinions that's again, when we're looking for diversity on the curb, we look for diversity across the board of differing opinions, and then we gather data to support any decision or support making any decision.
And just if I could follow up on that, how do you gather the data?
Well, we have clinicians that are staffed at DIVA, so that's with the reduction of the prior authorization requirements that we talked about last week, it frees up our clinicians to do some deep diving, and we have contracts with resources that are available with clinical articles, clinical resources that we can explore and bring back to the team. But we have clinicians that can do that and do that.
And, okay, I'm wondering, what I'm hearing is you're not talking to the people that are actually impacted by those particular services,
The patient,
the patient,
not the provider.
The
Yeah.
members.
yeah.
You're right. We're not. And that could be a gap. I can see how that might be a gap. And I
I mean, who
think
can tell you better than the individual experiencing it, whether it's effective or not?
we do have a public comment for CURB. Part of the CURB agenda allows for public comment. And I'm wondering if there's a way that we could notice people better to get the public more involved in that part of the CURB, where if somehow we noticed folks that we're going to be talking about acupuncture on March 15th, and then they could come and talk about it. But we certainly could involve interested parties. That's great. That's something I can take back. And I think that is something that, we could ask the folks who asked for the exception, if it's okay if we share their story or if they'd be interested in it. That's certainly something we could do to expand that voice.
Yeah. And another way you might want to do it is to deal with the hospital. I know UVM has these services that they provide. Talk to the people that are going through it at the time.
Well, I think the chronic pain initiative, when I send that information to you, I think you'll be happy to see that we're involved in that. It's been a year-long project that
Yeah,
talks about.
I agree with you on that. And I'm going to love to see that. But as a person who's going through treatment, there's psychological things that happen. And sometimes, I don't know what the results are of that with everyone that goes through it, but I do know that it really helped some people. Probably a lot of them.
I'm
And
sure.
I think it would be important to find that out before we
Agreed.
start saying, no, we're not going to cover that, or yes, we are going to cover that. So I'm just bringing it up as another way to get information and data.
I like it.
Art?
Yes, Sandy, thanks for your presentation here, but my question might be for you, Lori, more than Sandy or both of you. When the board convenes and makes these decisions, do they come to us and we implement these changes? Or can they implement without us?
I'm gonna let Sandy answer.
Okay.
Yeah,
Without legislation, I guess is what I'm wondering.
Yeah, their responsibility is to make recommendations to the commissioner. So they may use their expertise and analyze data and then say, we really don't think cone beam imaging should be covered. And then we would go back to the commissioner, and ultimately the commissioner would make that decision. The CURB makes the recommendation. And then a lot has to do with budgeting, maybe, or whether it aligns with the values or what we're aiming to do. So they advise. they don't implement.
And Sandy, if you needed legislative action, Diva would come to us and ask for legislative action.
Yes.
Okay, so what would trigger legislative action then in trying to see this? If more money was needed?
More money was needed, if there was something in language today that prevented whatever they were trying to do, most likely it would be more money.
Okay, so if they decided to add, say, acupuncture, I don't even know if it's covered, maybe it is, I don't know, but say they added that and took away something else and the money was flat, they wouldn't need our input probably,
Correct. And we may never know.
and we may
So
never know.
We hear maybe someone would complain that they don't have access to it.
Oh,
anymore.
okay, right, okay, I'm just trying to get a sense of the interaction here and what our role in all this is. I know it's always money, but.
But I think you're getting to the point of how would we know? So
Yeah.
that was the intent, right? So let's understand, because everyone's always coming to us, like, let's cover Medicaid
That's it.
transportation, let's cover acupuncture, let's cover this, cover that.
Let's expand Medicaid.
Right, exactly. Exactly. So we're just gonna do it all at once. So my intent was, what's the process,
Yeah,
right? And
yeah.
can it be more transparent as to what Diva, whatever team is looking at it,
Yeah.
what they've looked at, not just what they're changing. So what they've looked at and then why they made the decision, utilization, financial, whatever the case may be. And it would help get it out more to the public. It would help get it out more to other legislators, providers, to be able to have that type of transparency.
And the second part of my question is, how does that bleed over to private insurers? I mean, if Medicaid adds a service and the privates don't have it, what happens there, if anything?
So
They don't have to, I know, but
they don't have to, and it's a whole other process.
yeah,
If we legislate that commercial insurance
right.
covers something. And we've talked about this and we had to cancel the testimony, but Jen Barbie, Legislative Council, will come in at some point and talk about that because, again, that's a whole other process with whole other budgetary.
And I'm thinking, one final thing, I'm thinking about how we handle Medicare covering hearing aids. Because we maybe, I know it's
Yeah.
Medicare, but
Medicaid.
or was it Medicaid?
Yeah.
We handled that as a specific thing and I
Yeah.
wondered,
Yeah, that's a really good point. So that's,
here.
excuse me,
No.
that is, we had to change our essential health benefit package, right? And and we can have Jen go over that too when she talks to us on the other one. That was a specific process we had to go through to get that covered. And if you remember, when we looked at hearing aids, we also looked at fertility
yeah,
and looked at the cost. And we said, well, we're not going to do fertility,
yeah,
but we do want to do hearing aids, right?
yeah.
Marie, is that what those bills, when you put them on, they were put on the
Yeah, so
side?
some of those are Medicaid and some are commercial.
But that's part of what you're talking about.
Yes.
It's like that there's that other component.
Yes, yeah. Leslie, did you have a question? I didn't mean to cut you
No,
off.
no, I was just blatting, but, because we did the DEVA technical corrections bill last session, and that included some expansion of benefits. So that's another way that we did, it. I don't know if you recall that technical.
Right.
Yeah,
Because they needed some language.
yeah, they wanted some
change.
language to
I
support
don't
their
remember
expansion.
specifically,
Yeah,
I
but that's
get
how we did it.
Yeah, yeah, yeah.
So, Sandy, do you have section 7 in front of you by
Yeah.
chance? Okay, so I just want to walk through the changes that are here and just understand a little bit better. So one change, which is section A is just clerical, I think, or section B talks about 10 members with a diverse medical experience. So you already have 10 members, right? And they're all appointed by the governor, correct?
Yes, but on the recommendation of the commissioner. So it's a lot of our recruitment efforts that make that happen. That's where we think it could be challenging trying to navigate this. Again, we have 3 openings. Happy to have recommendations for those 3 openings, but trying to navigate who's what with their certain terms, it could be an impediment to recruitment.
Okay, and if there are ideas of how we could help you recruit, please let us know. I will say, I think having read the minutes and having read the report, and you did not say this, which I appreciate, I'm not sure having, well, I'm not sure this is gonna help, but it would help in that it would not just be the commissioner recruiting. So you're not necessarily against this, you just don't want to make it burdensome. Okay.
Correct.
And then if we keep going on to page 14, consulting with the department's DURB as appropriate, which, are you doing that today?
Yes,
So is that language necessary?
no,
Where are we?
Page 14,
16,
or
right?
17, 18, and 19. I'm sorry, Sandy, what?
I have, it's different for me. It's page 16 for me, sorry,
Oh,
Yeah, okay.
right?
oh, sorry, I'm using the, yeah, sorry. That's my fault.
Which one we on then?
Section 7,
Yeah, okay.
page 16.
16. All right.
Okay.
Let me pull up the one that you want. And then
Sure.
I believe on the next page for everyone, there's a E1 added, at least annually, the commissioner shall report to the committees. The services of the board is reviewed, considered, or recommended. So that's where we're talking about, can we make that more transparent?
So we do that now, but I think what you want is you want to know also what the multidisciplinary team does.
Right.
Yeah.
So everything that was looked at, why the decision was made. So if you can suggest language, you don't have to do it right now.
Okay,
Or I can, let's talk, I can rewrite it and see if you accept it.
yeah, I almost think that it just, you saying that you want that, I can incorporate it into the report that's being done now. It's just a matter of expanding that report a smidge.
Okay. Yeah, go ahead.
So is that report in statute, or that would, if we added it here, would make it in statute, which
It
then
is.
means we would automatically get a copy.
I thought it was already. We're
Well, that's
required to produce that.
The CURB report is required to be produced, but it does not provide the information that
So that's why we want it in statute so that we can get it.
we would expand that, yes. All right, and then the next section, within 30 days following receipt of an inquiry from a legislative committee. So I understand the 30 days may be problematic with the way the CURB is. And so I'm just thinking out loud. Did you have any comments specific to that?
Yeah, I'm wondering if you do revise, if you want to revise what's included in the annual report, you can also, you can say something like that we're required to, bring legislative, whatever it is that you're asking, to the CURB, and that we must include in the report the action that was taken.
Okay. Okay. So our intent will be, and we'll talk about this as a committee, would be to change the language, to change the update what is needed in the CURB report that's already sent to us annually. And then the process of how we would share information of what we want them to look at. So we're going to take a couple of minutes and talk about that here as a committee, but any other questions for Sandy? Great, thank you, Sandy.
You're welcome. Have a great afternoon.
Thanks.
Bye.
So does that make sense to people? Do you think it's necessary? And I don't know if anyone's read the CURB report. It's a good report, but it doesn't provide a lot of details of what has been looked at. So what is Medicaid looking at to cover? And why are they making the decisions that they're making?
It's super helpful so we don't keep reinventing the wheel. And if they've already had review of something and at least understand what their rationale was for either accepting it or not. And then if there's something that needs to be addressed later. So I think expanding the report is great, if not everything needed.
Right, that does seem like it's a piece of it.
Yeah, I agree. I mean, it would be like a reference guide for people who want to get something approved. They'll know what the process is and see, okay, why isn't it getting approved? Well, we can get the data to prove, to help get it approved. So
Right.
I think it's useful, like the person I've been communicating with about acupuncture. So
They're doing the work, it's exciting to
Right,
have it. Like, let's-
exactly, they are
let's
doing
do
the
it.
work, yeah, yes, exactly. Chopper?
Sometimes I get skeptical about reports that are written by professionals. So I would like to see some kind of way that, patients could have some input into this report.
Yeah. But patients would have input into what they're
Yeah.
looking to cover.
Yes.
Yes, that's what you want. Not necessarily the writing of the report, but,
No,
okay,
no, when they're collecting data,
yeah,
I think it's the strength of our process.
talk to people who are affected by it.
right.
Because I think everybody knows, sitting around this table, professionals feel a certain way about something, they feel that, they call it alternative medicine, et cetera. Well, guess what, folks? Sometimes, not just sometimes, because that sounds like a little bit, but a lot of times, people are helped by it. Just, I'll take one, marijuana as an example. Everyone's again, don't do that. But now you find out that it helps people with pain, it helps people with other things, and now it's being recommended by the very people that said, 5 years ago, 3 years ago, don't touch it. I just feel that it's important that we talk to people that are affected by it.
Right.
And I think it's the strength of our process is we try to get testimony from people with lived experience. So I think making that more robust in their process, or at least more transparent, is a great suggestion.
Anyone else have any comments before we move on?
So it sounded like Sandy didn't really feel like this was necessary, the whole section.
I think,
Is that I
She's
don't
already
wanna
left,
speak to
yeah.
her or anything else, but I just, is
So-
that,
what I heard was, they're not opposed to us changing the way the members are appointed, as long as it's not burdensome, because they already have 3 openings, so
right.
some ways it might be,
No,
it might help, because we have more people
Sure,
looking for that. And then, she said, G, we're already doing today, where they coordinate with the department's drug utilization review board. And then, I will change the language I'll work with Jen to say, we want that work plan process to be more transparent. So let's change what's required in the report we're getting annually today to include the things we want to see.
oh, good.
Yeah, so I don't think they were opposed to any of it, and I
Yeah,
think talking through this, we both, I've learned quite a bit, so.
Okay, there's a lot of stuff here, but we're not really doing.
We're not really changing a whole
No,
lot, right? It's just the
that's what I
underlying
thought.
stuff, yeah.
That's what I thought, yeah, okay.
I think the composition of the board is interesting and important. And I'm just looking at the list, and it's 1, 2, 3, 4, 5, 6, 7, 8, 9 MDs, 1 dentist, and 1 naturopath. So there's really no one representing alternative views, I think, like what Representative Fawn is saying, or the patient. Now, it may not be appropriate for them to sit on the board. I'd have to understand more about that and those kinds of decisions, but it is pretty narrow in its focus or in its participation.
Okay.
And I think it's pretty easy to get people with lived experience. I'm going to use my own personal thing. When I was going through cancer treatment, I was receiving things that I never heard of before. I said, I'm going to try everything just to make, I don't miss anything. But after you get, that's all for nothing. It's part of the program. But afterwards, those things that help you, you got to pay for it. And the insurance company doesn't cover it. Sometimes people can't pay for it. If we're talking about the Medicaid, that's the very people who can't pay for it.
You can't.
So what
But it will help
about,
them.
yeah. If I could build on that, we may be saving money down the road because these treatments are preventing more expensive treatment. So
Yeah.
it's really hard sometimes to understand that, those consequences too.
And just in terms of people that could fulfill this role, after you, when you're going through, I don't know whether you end up every single time, but I ended up in a group of people where we met once a month and talked about how we were doing. And those people would be wonderful people to be on this board. Or they solicit information from them. That could be a topic of one of their meetings.
So I'm getting a voice from afar reminding me that we have something called the Medicaid and Exchange Advisory Board. So I'm just saying that out loud now, so Ashley knows we're going to ask her about it in a minute. That might help us get to a little bit of this. But before we go there, any other questions, comments specific to this?
My only comment would be that in the way it's written, we have appointments coming from outside of DIVA, and that might help support broadening it. So I'm thinking that I would like more conversation about that.
Okay, yeah, you mean the language that says that the
Speaker
and the pro tem would,
because they don't have to necessarily appoint legislators. They could appoint,
yeah, I would hope they won't be legislators. We're not the right people to be on the.
right, that they
Yeah.
would somehow, we would be able to.
Yeah.
That would be a vehicle. I don't know if it's the right one, but it's.
Okay, so now we're moving to sections 4 and 10. Ashley, are you there?
I'm here.
Hi,
Hi.
how are you? Good to see you. Welcome to the committee. So I don't know, you came on late, so I'm just gonna update you a bit. So Sandy Hoffman was on talking about section 7, which is the curb. And the intent was to say, we wanna have a better understanding of, we get all these bills on our wall to say Medicaid, can you cover this? Can you cover that? We hear from constituents, we hear from legislators. And in drafting the bill, the intent was to have a more transparent process of how that works. And instead of having a one-off, us taking up 5 different bills and having to work with you all through a session, is there a better way to look at what DIVA is looking at to cover and why decisions were being made, and then what we as legislators might want you to look at? I'm saying all that to get to the part where we talked to Sandy Hoffman and we have some ideas on how to move forward. But Topper was talking about the fact that today it doesn't seem that, and Sandy said, CURB isn't really hearing from the member or from patients who might be impacted by, say, having acupuncture be covered by Medicaid. And so our legislative council reminded me that we have a Medicaid and Exchange Advisory Board. So can you tell us a little bit about what that board is and how Medicaid members are involved? And if I'm putting you on the spot, just say so. And we'll have you come back.
I'll do the best I can. So for the record, Ashley Berliner, the Director of Medicaid Policy for the state of Vermont. And the Medicaid Exchange and Advisory Committee is actually written into statute, and it is something that is held once a month. We have 2 chairs of the committee that are outside of the state. They're nominated and elected. The actual makeup of the committee exists of providers, affinity groups, members, so beneficiaries, and other interested parties. Sometimes we have small business owners because the exchange is part of the advisory committee. The specific numbers in terms of breakdown, I would have to get back to you on. I do think that there is a specific percentage that has to be beneficiary, but I don't know off the top of my head. And that committee, as I said, it's chaired by two members, and they determine what the agenda is. The commissioner of DIVA is there every month. They set the agenda, so they hear often about what is being talked about in the State House. They often want updates on renewals and other enrollment activities. Sometimes they want to hear about policy conversations that are happening with the federal government or corrective action plans that are happening. So it really runs the gamut of everything that to have to do with Medicaid program.
Okay.
And I
Thank
see
you.
Mike Fisher just walked in, and he certainly knows a
Yeah.
lot about that as well.
And we're talking about the Medicaid Exchange Advisory Committee, and Mary Kate Molman is also in, and she is the current chair. So do you mind stepping in for a moment? Actually, do you mind if we diverge a little bit on this? Okay, thank you. Because you've been in the room and you've heard the testimony, so I don't know if you have anything to.
Yes, so for the record, Mary Kate Molman, Director of Bi-State Primary Care, Vermont Public Policy for Bi-State Primary Care Association. So I currently serve as one of two chairs for the MEAC, the Medicaid and Exchange Advisory Committee. We typically try to have diverse views as with the two chairs. So for example, I come from a provider perspective, representing a provider association, and my co-chair represents a consumer. So she really brings the lived experience of being a Medicaid member, and that experience of receiving the services, the challenges that she faces. So it's an interesting dynamic with the two of us. I think Ashley did a great job of describing the role of the committee. It's really focused on what can we do to advise the commissioner on policy priorities. We recently voted on a measure put forward by Mike Fisher to advise the commissioner to work with the legislature on how to provide more support for Medicare enrollees through making care more affordable for Medicare enrollees. That would be the Medicare savings plan that you have in H 721. And now we have, and I want to actually be really clear, we did not vote in support of that bill. We actually, as a committee, were very deliberate in our role, and that we are not there to advocate or oppose any specific legislation, but to identify policy priorities that we would like the commissioner to focus on. We typically write an annual budget letter with our recommendations for what budget priorities should be. This year, it went out around November to the commissioner this year, but next year, we really want to change the timing of that so that our budget recommendations to the commissioner can come out in a more timely way when the administration is starting to turn their attention to the next year's fiscal year budget. Recently, we had a great conversation with Pat Jones, Director of Healthcare Reform, talking about the AHEAD model and how, while that's focused on Medicare, there's a strong focus on also aligning with Medicaid. And so that was an opportunity for members to hear and provide input on potentially Medicaid's role, should we move forward with that model. So that's kind of a broad overview, but we hear about things like what's happening with our durable medical equipment and the supplier, and that gives the DIVA staff an opportunity to hear what are the challenges out in the fields, and also for especially the provider and consumer organizations to hear like what DIVA is doing about it. But yeah, that's kind of a broad flavor of things we talk about, but I'm happy to answer questions.
So, and I appreciate you coming up unprepared, so thank you. So if we have questions and you're like, I don't want to answer that right now, that's fine. So does this committee consult at all or hear from or have any connection to CURB when CURB is determining like things that should or shouldn't be covered?
We don't
but I would be interested in hearing more ways where we can connect those pieces.
Okay. This could be an avenue to do that.
Yeah.
Okay. Any questions for Mary Kate? Great.
So put a plug, there are opening seats, so if anyone knows of anyone.
Right, yes. 3 members we need to get. Mike, would you like to testify? We have time. Take a seat.
I apologize, I missed some of the discussion about the advisory committee. But can I just sort of make a broad comment about what I saw in this section and what I think has been mostly expressed, but maybe I haven't heard it as clearly as I want to. I think what I heard out of this proposed language was a more deliberative way of evaluating what's not covered. It's sort of on a, sort of most value for Vermonters. What comes onto the wall is at the whim of what your constituents bring to you. And so breast milk coverage, it sounds great and is important, but it's at the, I don't know how that idea came to Representative Cordes, but
it's important to someone in our
somebody.
state. Yes.
And so that's an important way of getting ideas to the table, but it's not necessarily, there might be things that are of really high value that nobody is ever going to bring to one of you guys.
Right.
And so I guess what I was seeing in that was a request that there be a more professionally informed process of evaluating what should be considered.
Yes.
And maybe that's happening, but I haven't heard that.
Well, I think that I agree with you. And I think the first step is we need to make it transparent. So we can understand how that process is happening. And how we can make it more transparent and more professional and get to the meat of what we're trying to get to.
And then if I could just say, only half joking, when I was chair with Julie Tesler, we call it the MEAB, Medicaid and Exchange Advisory Board, even though it was really a committee. And I hear people now often attempt to call it MEAC in an attempt to not call it MEEK. And so you'll hear me always say the advisory committee. I don't mean to suggest that there should be any change in its function or anything, but I think it should be called a board so that we can have a better acronym. Otherwise, I've threatened to rename it a committee that speaks in a very small voice and nobody listens to.
Writing that down.
Sorry for my diversion. Thank you. And by the way, you have a former chair here, you have a former chair here, and Mary Kate left, and so.
Yeah. It's amazing what we don't know.
Yeah.
Right?
You don't know either.
Yeah, what we don't know. So this is great. Okay, so let's let's table this. What I will say is I will work on language. I'm happy to take input from people and we'll change that section around a little bit, but I think we all agree there's some interest there. Okay, so we're gonna go back to Ashley. I'm gonna pull up the bill so that I'm looking at you all. So why don't we start with section 4, Ashley? So this is to get everyone on the same page. This is
Page 12.
Yeah.
page 12.
Very global commitment.
Global Commitment Fund. Okay, and I will again set the context here. So since I'm the sponsor of the bill, so under our Global Commitment Fund, and Ashley is going to do a way better job of this, so I'm going to be very brief. We have things called investments. And in the 8 years that I've been here, I'll ask for a list of investments and I get a list of investments that's about this long with really tiny print that says what the program is and how much the investment is. And we don't have the time to drill into it. It's hard to follow. And so the intent here is to say, we need to start understanding where that money is going. So it's normally, it's an agreement of a program, could be around for a while, could be very new. Money is being spent on something. we should be able to know what that something is. Is it working? Is it helping Vermonters? Is it doing what us and Diva wanted to do, or whoever suggested it? And if not, is there something else we could be doing? So that's the general gist of the intent. I'm going to turn it over to Ashley to talk more about section 4.
Thank you. And just to note, I have been asking the same questions for maybe 5 years longer than you. So
Yes.
very much relate to
And I appreciate that.
the intent of the bill. So as the chair said, we have a long list of investments. We have 82 of them, and they are programs that are funded with federal Medicaid dollars that otherwise wouldn't be federally fundable except for our 1115 Global Commitment to Health waiver. So the typical Medicaid program says you can have this type of services for these individuals provided by these provider types, and there are strict laws around what Medicaid dollars can be spent on what. Our 1115 waiver is really unprecedented, and that it gives the state of Vermont flexibility to use federal dollars on things that are not otherwise matchable with really broad discretion. We have pretty high level buckets that say they need to be things used for things that promote public health, promote equity, really big, huge categories that you can put a lot of different programs in. And we were very strategic about how we detailed those categories so that we have capacity to fund things that are otherwise not matchable. So that's kind of the background on what the investments are. And absolutely right that we haven't done a great job since getting this authority of really understanding the efficacy of what we're paying for. Is it doing what we intended for it to do? Is it something that could be scalable or not? Should we be actually pulling it back? Should we be scaling it up? We haven't been able to answer these questions. We've had really kind of rudimentary scorecards with pretty basic outcome measures over the past decade. And when we negotiated our last waiver, one of the commitments that we made to the Centers for Medicare and Medicaid Services was that we were going to do a better job of understanding how this money was being spent and whether it was promoting the outcomes that we desired. And so we're right there with you that we want to be understanding these investments. And as such, we've contracted with NORC out of the University of Chicago to do a really robust evaluation of our investments over the course of this demonstration. We are contracting with them from now until 2028 to go through kind of a systematic review process of some of our investments, 8 to 10 per year, to come back and tell us whether what we're doing, what we intend to be doing, is actually happening on the ground. So answering that question of, is anyone better off? Is this something we should continue or not? Is this something that we should promote or scale up or not? So we really agree with the intent of this language, but there are some specifics in it that we think need to be modified in order to better align with the work that the agency already has underway. For instance, the language says that we would be reviewing 20% of the investments per year, and would rotate the investments. That 20% of 82 is 16 investments per year. As I said, NORC is looking at 8 to 10. And if you do the math, 8 to 10 over the course of 4 years, 5 years does not add up to 82.
Right.
And so the reason for that is, of the 82 investments, 23 of them are time limited investments that we're using home and community-based service FMAP funding for. And so they are for things like really quick trainings or getting money out the door for retention and recruitment payments. We're doing evaluation on that at a kind of much less sophisticated level because the timeline around those investments is so quick. So that's 23 that are kind of outside of the normal process. And then there are just a lot of investments that we pay for that aren't appropriate candidates for this type of assessment and evaluation. And just some examples of that are we pay medical bills for kids in DCF custody. Like the paying of the medical bills for kids in custody isn't really something that we need to evaluate. It's something that we need to do. We can either get match on it or we can't, but we have to do it as the Department for Family and Children. Another example is we get federal match for cash assistance programs that are administered by the Social Security Act. That's not something that we have any discretion over. We have to, per the Social Security Act, administer these cash assistance payments for age blind disabled. And this investment just gives us federal match for it. So the spending the money to evaluate is just not very fruitful in that situation. There are a handful of investments like this. Drug cost sharing for low income people with HIV. We want to pay cost sharing for that. The evaluation doesn't need to be that sophisticated, right? So just to kind of whittle down the 82 for how we got to the 8 to 10 a year, because when we looked through that list of 82, there were about 40 that were really big questions for us. Is this working? Is anyone better off? Is this something that we want to continue or scale? And so we're asking the committee to really align this language with what our NORC evaluation is already doing and allow it to be limited to the evaluation that NORC is looking at on an annual basis. And we'd also ask that the language around return on investment be stricken. And this is specifically raised by NORC, the researchers at NORC, because for them, return on investment is a very specific term of art that requires a very specific type of evaluation that is out of scope. So they will be conducting rapid cycle assessments that are focused on outcomes, process, and impact, but the capital ROI is not something that they will be evaluating.
Okay. Is there I think we have a couple questions, but first, is there anything that they are evaluating that's not on this list that we shall and should include?
Oh.
And you don't have to answer right now. That would be one, as we look at changing the language a bit, that would be one thing.
I can certainly get back to you on that. And I will say, the intention is to, with or without this language, the intention is to share that evaluation.
Okay. Thought I saw a hand up. I forget who. Art,
For me?
do you have a hand up?
Yes, I do.
Okay, go ahead.
Yeah, thank you, Ashley, for this. Your testimony is on opening a lot of doors here, although I'm afraid to walk into a couple of them. Because I'm trying to understand. When you say investment, okay, we're again, repeat, is this Fed money we're investing or state money? Which piece of Medicaid are we investing? Or is it both?
It's both. It's federal match for our state dollars. So
Okay.
every 45 cents on a dollar, we get 55 cents from the federal government.
Okay, but we're investing both.
Yes.
When you say investing though, when you first said it, I'm thinking we're taking the money, putting it in some sort of stock type thing to make money. That's obviously not it. Okay, so when you say investing, what do you mean by investing? You have 82 pots and you throw money in each one and then draw out to the client, the person that needs it? How does that work?
Yeah, thank you for allowing me to take a step back. So investment's the term that we coined in 2005. And we are a public managed care like entity at the state of Vermont. So unlike a commercial healthcare insurance plan that has stakeholders and charges premiums and generates a profit or a nonprofit to reinvest, we generate savings. And so the concept, which is a little bit of a wonky one, is that by having an 1115 demonstration waiver, we're able to change the way we administer the Medicaid program in a way that generates savings, where we're actually spending fewer dollars on our population. And instead of the feds just taking all that savings away from us and not spending it, they're allowing us to reinvest the savings in innovative programs. And so that's where the term investment comes. where we could just not spend it. We have the authority to reinvest and get the federal match for things that otherwise are not matchable.
So investment is kind of not a great word, kind of. Right?
Yeah, that's where I'm
It's a
still
legacy
confused.
word.
Yeah.
It's a legacy word from when it was originally negotiated.
Can you say,
For the record, in all 911 Joint Fiscal Office.
right,
The term investment, I think, came about when they negotiated the first global commitment waiver, and it's just sort of a term that's been used internally ever since. And I think continues to sort of get redefined with each negotiation of the waiver.
but so there's no, so what it is it's we're taking money, we're taking state dollars and federal dollars, and we're putting it towards a program, towards something.
Okay, something being the.
Something, it could be, I'm gonna just make it up. We're gonna pay for people to get acupuncture. So I keep picking on acupuncture.
Okay.
So it is and we can send you the list. Alyssa pulled it up, like one of them, read one of them.
Hold on, gotta take my glasses off. Let's see, therapeutic childcare, Lund Home, the Lund Home.
Okay, so you are putting it toward those specific things.
Yes.
And if it gets drawn out more than there's money in there, you take it from somewhere else and put it in?
No, it is, and correct me if I'm wrong, Ashley, it's a set amount that each program has, or how does the money flow?
It varies based on investment. There is no rule of thumb. So something like Lund Home was based on caseload and utilization. So it wasn't a specific $100,000 for Lund Home. It was based on how many people went into the home and how long their stays were. And so that fluctuates. So we have several investments that are based on caseload and utilization, where we pay like DCF medical claims for kids in DCF custody. That fluctuates. We're always paying it. It's not a set amount. Then we have other investments that are set. We pay a specific amount of money for 211 every year, and that's it, and it never changes. They vary.
Right. And one of the concerns I've had over the 8 years, and I think Ashley is joining me here, that some of these just go on every year. You know, they just keep going, and there's been no look to see if they're effective.
Really?
Yeah. So that's what we're looking
The genesis of this.
Yeah.
Is to see if there's even needed.
Right. Is it effective? Is it doing what the intent is? You know, I think Ashley put some of those questions out there. So.
Okay, so money is spread across all these areas in termed investments.
Yeah.
And then it's drawn out by the need of,
Yes.
for the given period of time.
Right.
Okay, thank you.
Great. Other questions for Ashley?
I'm just curious to know how she found that, because I'm trying and you're good and I'm not.
Okay, so we're not gonna do that right now. We're just
Okay.
gonna send it to you and then
Yeah, just send it
tell you
out.
after.
Just so we all understand what we're
Yeah.
doing.
Anyone else? So,
Daisy had hers, but.
oh, I'm sorry, Daisy, I texted her and I said, Daisy, I see you, and then I forgot. Daisy?
So I think you just touched lightly on my questions. I have 3. And Ashley, it's good to see you. Thank you for joining us. Sorry, I'm not in the room. I guess, first of all, I wonder if the investment programs are held to the same outcome measures. You noted that ROI is not specifically focused on, but I know, like, when we read the global commitment, the quarterly reports and the annual report, are the investment programs reported in there? That's my first question. My second question is, what's the average length of stay, if we could coin that term, for some of the programs that end up in here? For example, I know some of the HCBS services were in there and we moved them out last year. My third question is, how much money do we have right now in the investment programs? Both state match and then federal. And I know you probably don't have all of those answers now, but it would be nice to have them at some point.
Can you remind me of your first question again? I'm sorry.
Yeah, it was whether the investment programs are included in the global commitment quarterly or annual reports, and whether they're held to the same outcome measures and standards that we report to CMS in those quarterly reports. I know you mentioned that they're not focused on ROI, but I wonder if they're completely outside of our outcome measures plan or not?
So what's in the reports today, the quarterly and annual reports, is what I was referring to as like pretty rudimentary. There, we spotlight investments. So in any given report, there might be one or two or three investments that we're spotlighting and providing really high level outcome measures. And they might even be things like how many calls were received at 211, for example, just to stick with that investment. So it's not really, in my opinion, very satisfying in terms of outcome evaluation and what we've committed to, and not in CMS's opinion either. And so what we've committed to with CMS is to contract with this vendor and really dig in and get more specific information with better measurements so that we can come back and won't necessarily be focused on ROI and like how much money we're spending on the thing versus how much we're getting out, but more focused on this is the intention of the investment and are we achieving that goal? That work just kicked off. We got the contract done late last year. They're just starting to work through those investments this year. And so we don't have any reports as of yet, but at the end of this year, we will have the first 10 investments. That's the first question. On the second question, the length of stay for investments, I love that term. Some of them have been around since 2005 when our global commitment waiver started. So some are very long standing and some of that is for good reason. As I said, we use an investment to pay for a portion of the public health lab. That's a huge amount of money that we just get federal match for. And so it makes a lot of sense that we would continue that investment ongoing. Some of them are just investments that got put in there and never got taken out and are just continuing on. So they all have their own story. And then in terms of the total amount of investments, it's about $120 million a year, gross.
So state and federal.
Yes.
Great. Thank you. So Ashley, I am super excited. Because I know we had talked last year about, you know, the need to try and hire a consultant. So I'm so happy that this is moving forward. And I do think it is something that we should still keep in legislation. I want to make sure we see it through to the end. So I'll connect with you on language up changes. Great. So if we're good with that, we're going to go to section 10, which is on page, all right, you're always good at this.
19.
19? Thank you. Okay, and so I'm going to start this with, again, my intent when this was written was honestly because I had received a report from someone within the healthcare field, and this is being done in California. I will tell you, I don't even know if it's an issue here, but I thought California is doing this. It's so great that we should look at being able to help youth have access to mental health without having to be, given a diagnosis. And so that's where this is. It's pretty, it's just something they put out there and we'll see kind of where it goes. So Ashley, I'm going to turn it over to you.
Thank you. So this section was really helpful for us to kind of dig into because it was not high on the radar at Medicaid that this was something that was being kind of worked through by other states. After seeing this language, we have dug in with California to understand exactly what they're doing to allow individuals to receive mental health services without a diagnosis. And we are exploring those channels currently. We're actually very interested in going broader than what this language states today. This language has a list of 9 social determinants of health that says that individuals would be able to receive mental health treatment without a diagnosis. And what we're currently exploring at DIVA is not limiting it to that list and broadly allowing unspecified mental health diagnoses. We still have a lot of weeds around correct coding and primary versus secondary diagnosis that we have to work out. And we are doing so with California and with our own clinical team. But we are actively pursuing this and are committed to making this change with or without this legislation. We think that the language as written is limiting, and so we would prefer not to have it at all, with the commitment that the agency is moving forward.
Okay, Brian?
When that this might be a question for you more than our witness, but like, are these, looking at them, are they aligned with the ACEs? Are these like aligned with ACEs? Like,
No.
Okay. All right.
They honestly were
Okay.
a list that we developed because we thought we knew it was best.
I mean, it's not, it's, they're all concerning things, but I could see your point, which is that there's more. So like, why limit it to the list, you know? So.
Yeah, absolutely.
Yeah,
And I'm
yeah.
happy that you're starting to dig into it. And I'm cognizant of the fact that we don't want to have language that limits
Yeah.
anything. I'm curious if you have thoughts on like a timeline. It's like, I'm wondering if we put in language that says, report back, not reports, like not a report, but come back. And part of my reason for wanting to do that is we don't know who will be in these chairs next year. And so it would be good to have something in statute that reminds everyone that DIVA has been looking at this.
So in terms of timing, I think we're going to be able to get something done here in the next month or two. We don't need any federal approval to do this. It's our own kind of coding instructions, and we have a lot of discretion there. We're really right now just working through the materials that California has provided to make sure we really understand that it's not worth getting into, but the coding with the diagnosis placement.
Yeah, we're not going coding.
As soon as we figure that out, we're going to make the change, and there'll be public notice around that as well. So people will be seeing that, but I mean, definitely before this session is through, we'll be able to report back.
Okay, Leslie and then Brian.
I'm just wanting to understand, I'm not going into coding, but I just want to understand, is the issue, the underlying problem coding? So that if you don't have a code, you can't bill? That's what I'm trying to understand that. Is that what you're saying?
That's kind of the crux of it, is that you need a diagnosis in order to bill. And so this language tries to get at not having a diagnosis in certain cases. And that is, then we get into semantics and proper billing, but that's what we're trying to work through, is how to make sure that we're not unnecessarily attaching a diagnosis to these young kids and it being a barrier to mental health. So there are some tricks of the coding trade that we can use around unspecified things that still allow us to do that correct coding without labeling a kid. And that's what we're working through.
Right.
What about the potential down the road to do this for all people? Because I understand why we would start with young people, but people can get, that people can be mislabeled or misdiagnosed due to because I mean, diagnosis in mental health is generally like a judgment by a provider, or at best, like a decision that is made between the provider and the patient to pick a label for the problem. But like, it's not like there's tests that can determine that for every single person. There's psychological tools and all that, but all of these things like can generate labels that are oppressive at any age. So I guess like, I see why we would do it with you to start, but my question is like, has anyone looked at doing this for all people? Or has it only been done with young people?
Our research to date has been limited to kids. And that's what California has limited it to as well, which is who we're kind of looking towards. We certainly have clinicians that could come speak to you about the diagnoses and importance or not importance of that at any age, but I unfortunately am not equipped to speak to that.
Good question and good point. So what I'm thinking is we take this first step. And so I'm thinking remove it from the bill, plan on having you back in our committee before the end of the session to see where we are with this. And see how it plays out, and maybe, you know, the next committee can talk about the adults as well. Leslie?
I just want to understand, are you saying taking out section 10?
Yes.
Is there a reason to keep it in only to get, not a report, but get information from where they stand by the end of the session?
Well, what I've heard from Ashley is that this language is limiting, and this language won't go into, I mean, this bill won't go into effect until after we're out
No,
of.
I understand that part, but is it possible, we can take this language out, I get it, the limiting and whatever, but include some kind of language that says we want to hear back.
But we are going to hear back before the end of the session. So what I'm saying is it won't help being in a bill because our hope will be hear back this session.
Okay, I guess I'm feeling worried. But I'll let go of my worry.
Yes, we'll make sure that we reach back out, and if it falls apart at Diva and it's still something that we want to do, we can work on putting it on a bill if we have to. But I feel good that.
Well, here you're right. Section 10 is being eliminated.
That's what I am suggesting.
Okay, so you suggest.
I'm suggesting it. We can talk about it, but that's my suggestion. Since they're based on section 10, they've jumped right in and started doing the work, which is great, and can get back to us before the end of the session. And then we can decide what we would need to do from there. Brian?
I'm okay with that. I think if people were not okay with that, the only thing I would consider at this point, because I would not want that language in there because it's not helpful at this point, would be like a statement of intent or something where it's like, it's the intent of the General Assembly to work with Diva to, you know, ensure that that there's a pathway for people under this age, you know, to access treatment without a diagnosis. I don't think it's necessary, you know, but I'm just saying, like, to me, that would be the compromise. But I would not want to leave it as it is because it limits what Diva can do. Yeah.
And I would say, let's see what they come back with
Yeah,
before we
yeah.
put intent in.
Yeah.
Does that seem to work for everyone? Great. Ashley, was there anything else from your?
Not on those two sections. I will just say, though, very excitingly, we also have signed a contract with the University of Massachusetts in partnership with the University of Vermont to do an evaluation of our entire Medicaid program. So we spoke about this a little bit last year as well. So we have the investment evaluation and then the whole Medicaid program evaluation, which is a 6-year evaluation that I think is going to be really a game changer in terms of the data that we have available to think about the outcomes in our Medicaid program. So just an exciting point.
Yeah, that's great. Leslie?
I'm just curious to know what the time frame is for that.
For the evaluation?
Yeah.
It's kicks off tomorrow.
Whoa.
And it is through 2029.
So it's going to take that long to get a good evaluation.
We're gonna get the infrastructure up and running. We should have reports coming out by the end of 2025.
Great. I was gonna say, this is really exciting that section 10 is already in process.
Yeah, isn't it great?
It's just so great.
Yeah.
Thank you for the good news, Ashley.
And really section 4.
And 4, yeah.
Right. I mean, that's, so I do think we should keep that in and make some changes to it, but yeah, it's really exciting. Brian?
Can you just share a little more about the evaluation? Because it sounds like it's like multi-year and there's going to be report backs, but like, is there a particular tool, like assessment tool that's being used for it? Are there particular goals? Like, I'm just curious, like what are they evaluating?
Yeah. So we don't have a comprehensive evaluation of our Medicaid program today. So in terms of like every dollar that we're spending on the Medicaid program, is it is anyone better off? We don't have a really good way to measure that. And so the University of Massachusetts is really the gold standard in looking at Medicaid programs across the country. And they have a very close partnership with MassHealth, the Massachusetts Medicaid program. And we kind of modeled that partnership. And we wanted to create it with the University of Vermont. And are so excited that they're going to be able to start building that infrastructure under the kind of guidance of University of Massachusetts. And so I don't have answers for you right now, Representative, in terms of like what we're measuring specifically and what tools we're using. They're going to be taking in all the data that you can think of and starting to play with it and ask questions of it and work with subject matter experts across the agency to think about like, what are the questions that we want to answer? What are grievance and appeals telling us? What does it mean when we see this kind of level of churn in our enrollment? Is this new service that we covered impacting ED visits, or is it lowering the cost of drugs? So really the sky's the limit, in my opinion, in terms of the kinds of questions that we can ask. The first step, the next 2 years, are really getting the infrastructure in place and the data in the data lake to be able to start asking those questions and putting reports out. So I do think it's a big game changer in how we think about our Medicaid program, but we're in early days. Kickoff meetings tomorrow.
So would it be fair to say, like what I heard is that the first steps are going to be data collection and sort of measurement, establishing measurement tools and data collection methods. And then that gives us time to think about the questions so that then we'll have a list of questions and we have the info. But right now we could have questions, but no way to even get the data.
That's right.
Yeah. Okay.
Art and then Daisy. And again, Ashley, if you can't answer the questions, just say you can't answer the questions. Art, Daisy.
Yes, Ashley, I assume though that the money portion, the dollars spent, that has been audited over time. Is there an audit process to make sure monies are spent properly every year? How does that part work?
Yes, I don't want to at all give the impression that we have not been completely responsible with our Medicaid funds. Yes, no, we are take that responsibility very, very seriously. I think it's just as data has gotten more sophisticated and more dynamic, and we understand social determinants of health in a way that we didn't 10 years, 20 years ago. The questions have gotten more complicated, and we really want to understand those interconnections and understand how moving one lever over here impacts a knob over there and vice versa. But absolutely, we monitor our utilization and caseload data and take very seriously the state dollars that are being expended on the Medicaid program.
But does the state auditor look at you folks? I mean, is there an actual audit done?
Yes, there is.
Good. Okay, thank you.
Daisy?
Congratulations on your partnership with UVM. I'm excited to see that analysis. And I'm curious, was that something that the legislature in part funded?
So yes, in the sense that the legislature funds everything, but we actually have a requirement under our 1115 waiver to evaluate our program. And so our evaluation has existed since 2005. It's been not the kind of robust evaluation that we're talking about going forward with UMass and UVM, but it is an evaluation nonetheless. And so we've had money to pay for that evaluation in the base. We actually received 90% federal funding for this evaluation. We were able to make the case that it was to further some of their IT goals and further some of their evaluation goals. And so we got 90-10 funding for this, which is really, really exciting, and is the reason why we're able to kind of make it as big as we can. So we were able to take that kind of small evaluation budget that we've had in our base for the 1115 waiver and really make it a lot bigger.
Okay, great. My real question is, where would I find it in our budget from last year?
Yeah, I can get back to you if you need specifics, but it would be in the 1115 kind of technical assistance contracting evaluation language, but we can certainly follow up if there's a specific line that you need.
Nope, I'll find it. Thank you, Ashley.
Well, exciting news that you've brought to us today, Ashley. So thank you for your time. We'll get back to you on the bill with some language changes. And I think we're good. Thank you so much for being here. Have a good rest of the day. And we are going to take a break unless there's any questions until 3:30.
What are we coming back for?
We are coming back to H766. Section 1, which is step therapy, which is about pharmaceuticals. Yes.
So
hold on, we're still on live. So don't start talking.
I will.
So yes.
I was just wondering, have we been through all of 721 at this moment?
Yes, we have been through all of
Okay.
721. Yes,
Great.
thank you. I was going to say that.
Okay.
We have been through all of 721. I will work on what needs to happen next, but there's different sections. We have to do different language. And Daisy, I see your hand. Hold on. And so we'll come back to that. I think we have a committee discussion scheduled. We're going to have a little bit more testimony tomorrow afternoon. People who still want to, a couple people who still want to talk about the Medicaid reimbursement rates. And then after that, we'll have a committee discussion. Okay. Daisy?
Is Mike Fisher still going to testify on 721?
Yes, that's tomorrow afternoon.
Got it.
Okay, so please be back here at 3:25 so we can start on time.